Hello everyone, today we will talk about Pemphigus foliaceus. Actually, it is an autoimmune blister disease that is sometimes misunderstanding as a Pemphigus vulgaris. Pemphigus foliaceus, let's say it is the mild form of Pemphigus vulgaris because both of them are autoimmune blister disease, but foliaceus affect superficial layer of skin while vulgaris affect deeper layer of skin. Foliaceus is actually characterized by circulating of autoantibody that is specifically an IgG antibody that affect the desmologen 1. Desmologen 1 is actually a protein that will keep the adhesion between skin cells. So when desmologen are lost, we will have a loss of skin adhesion, result in condition called acantholysis. This is actually simple pathophysiology. What patient come with is with multiple blisters, but neither the patient nor the clinician will able to see these blisters because these blisters are actually easily to rupture, so they will leave crest and scale formation that are visible and can be seen. These crest and scale formation are actually more in the upper torso and mainly in the face, scalp, the upper chest. These are mainly area that Pemphigus foliaceus affect. So, the history and physical examination, the patient will appear actually not severely ill, but will complain from burning, pruritus, and mild pain. And there are scattered lesions that, as we said earlier, involve the seborrheic area, which are the skull, face, chest, and the upper back. Nicolosi sign will be positive. So it will give us a chicken net pattern or fish net pattern that's seen on direct immunofluorescence. The diagnosis depends on the biopsy of the fresh lesion. Okay, and also we need a confirmatory immunological study, which is to document presence of skin autoantibodies. So when we take biopsy from fresh lesion, we will determine the area of blisters. But when we need confirmation of autoantibodies, we need from the peri-lesion skin area, the skin that seem not involved surrounding the crest and scale area. That skin is actually when we will find an IgG autoantibody. The hallmark of Pemphigus is actually, as we said earlier, is finding IgG autoantibody against the cell surface of keratinocyte and by direct immunofluorescence. This is a Nicolosi sign and it is positive. What Nicolosi sign is actually when we rubbing or when we give a gentle pressure by skin, there will be a blister formation because skin layer, the superficial layer, and especially the stratum corneum layer, it will be detached due to the weak adhesion because of loss of desmologen 1, protein desmologen. In cases of vulgaris, is actually what lost, or let's say what the layer is involved is the basal layer. So it's actually involved the basal while facialis is involved in the corneum. The first line treatment will be corticosteroid and the dose will be either 0.5 to up to 1.5 milligram per kg every day. And after that, we will assess the response for 2 weeks. If the patient controlled or not. If controlled, we consider giving an adjuvant therapy for more, let's say, controlling of the disease. And actually, the adjuvant therapy is still not now to be given either even when patient is controlled or later if the response is not what we want. So there are controversial between early given or visit resistant people. Cases of patient not controlled, we give higher doses of prednisone, and adjuvant therapy is still considered, as we said earlier. For refractory cases, we give hydroxychloroquine. We have multiple options like hydroxychloroquine, which is 200 milligrams twice a day, or we can give dapsone, or we also can give methotrexate or IV immunoglobulin. And other drug that's not mentioned here, but we can give rituximab. That's simple explaining about Pemphigus foliaceus. I hope you enjoyed during the explanation, and I wish you subscribe our channel. Thank you and goodbye.